All right, good afternoon, everyone. Thank you for joining us today for this session in the SPARK webinar series. My name is Kamran Tariq. I am Program Manager for SPARK Hub. We are a BARDA Accelerator Network hub focused on advancing medical countermeasures for pediatric populations. Before we begin today's session, just a few quick housekeeping notes. This webinar is being recorded, but we will stop recording for the Q&A session, so please do not hesitate to ask questions. If you have any questions during any point of the talk, feel free to drop them in the chat. And please use raised hand function if you'd like to ask a question directly, and we'll call it you. With that, I'll hand it over to our speakers for today.
Brian, do you want to share the presentation?
Yes. Pulling that up now.
Great, thank you. Thanks everyone for attending. We're excited to present this really valuable content to you all. I'm going to actually ask Ryan to advance the slides here. So go to the next slide. I'm Tanya Dowd. I'm the Executive Vice President of Reimbursement, Health Economics and Market Access and Corporate Development here at PRIA Healthcare. I have been in the reimbursement health policy space my entire career, about 30 years. And I provide strategic consultation to medtech innovators in the early stages of product development, all the way through commercialization and everything in between, developing reimbursement strategies and executing those. I have about 12 and a half years of experience from J&J, but have been a consultant for over 15, and am a judge and value coordinator with MedTech Innovator, Creative Destruction Lab, and various other biodesign organizations across the country. So that's me in a quick and dirty nutshell. I will hand it over to Ryan to introduce himself.
Thanks, Tanya.
Mm-hmm.
Welcome, everyone. Pleasure to talk with you all today about a subject that Tanya and I are very passionate about. My name is Ryan Nolan. I'm the Senior Director of Reimbursement, Health Economics, and Market Access at PRIA. Prior to that, I sat in a very similar position to, I think, a lot of you in the audience today. I was a pediatric medical device entrepreneur, biomedical engineer by training. And in that position, I led all of our clinical trials and reimbursement efforts for the better part of a decade, including obtaining new coding coverage and payment. Unfortunately, our pediatric physicians don't get enough new toys to play with. And so this is a space very near and dear to my heart. In addition to all of that, like Tanya, very active in the community as a judge and mentor for various different organizations. And I am a certified clinical research professional, given my experience in leading and managing multiple multi-site clinical trials through publication. Okay, I'll pass it back to you, Tanya.
All right, thanks, Ryan. Appreciate it. So today, just kind of the quick learning objectives. We're going to learn about the fundamentals of U.S. reimbursement and market access in the context of early product planning. We're going to look at the difference between how U.S. payers and the ecosystem in market access looks at new and novel medical devices versus how the FDA looks at new and novel medical devices and what they're thinking and what they are actually looking for. Understanding the importance of early product planning, and this is really something that we'll continue to hone in on throughout the presentation, but the early product planning is imperative for success in the commercialization state. We're going to pepper in some special considerations here for the pediatric patient population, and then we're going to review some common industry misconceptions, mistakes, and how to avoid them through our collective experiences. Next slide. Ryan. So we want to make sure everybody's on their toes right away here, and we have a little quiz. It's a little bit difficult to do this in the remote setting, but so I will maybe ask folks to raise their hand or shout out. Fine with that, and please do ask questions throughout if you have them. But the first question: FDA approval or clearance is all you need for the opportunity to achieve commercial success in the U.S. I see. Any responses? I see a couple.
Yeah, it looks like we got some thumbs down.
Yeah, exactly. So that is absolutely 100% false. Good call on that. Second one, if a reimbursement code exists that describes your product or service, you're good to go, and there is nothing else you have to worry about. Anybody think that's true? No, not true. Not true at all. Third, the market access strategy isn't needed, excuse me, at the early stages. It's more of an issue around the commercialization phase after regulatory. Anybody think that's true? No, false, definitely, right? We wouldn't be here today if that was the case.
Yep.
Next one. I don't need to worry about the reimbursement and market access plan because our company will be acquired before or right after regulatory clearance or approval, and it will be someone else's issue to deal with. True or false?
Seems like people are picking up on a trend here.
Yeah, exactly. Absolutely false. Absolutely false. The evidence required for FDA clearance or approval will be enough for commercialization and reimbursement success. The trend persists. Absolutely. All of these are 110% false. And believe it or not, we do hear a lot from prospective clients on number 4. And it used to maybe, kind of trend that way, but it's certainly not. Investors and strategics really want to know, and they want the proof, not just the proposition. So definitely something you have to have a plan for, and a thoroughly laid out plan with an expert company such as Priya to really share with your investors and your strategics. So next slide. So early planning, again, you're going to hear this theme throughout, is critical. And we want to kind of break it up into 3 different stages. What I call kind of preclinical strategic product planning. That's in the kind of R&D phase when you're kind of understanding and learning the market. And this is where we really want to understand not only the total addressable market, but the serviceable addressable market. This is when we're going to get into who the stakeholders are, what your pricing strategy is, what are the incentives and disincentives for your stakeholders, and are the stakeholders that you are assuming are going to be applicable or relevant for your technology. We need to validate that. Is that really true? Are those the true stakeholders? And it's important to get granular here because every eye isn't the value is in the eye of the stakeholder, and we'll get into that in a minute, but really understanding what those segments are. So early product planning, understanding the market, and really starting to focus in and hone in on your commercialization plan, which is really a key component of your commercialization plan, is your regulatory, reimbursement, and market access planning, right? And they all go hand in hand and are interrelated. And then your kind of commercial plan and market adoption. But really the reimbursement and market access plan is the underpinning and the critical piece of your whole commercialization plan and should be thought out throughout your product life cycle. Your regulatory plan can have implications on your market access and reimbursement plan and vice versa. So really, again, thinking about this throughout the product life cycle and early is critical. Next slide, please. Knowing the strategic intent of your product. Again, this is kind of in that strategic product planning section, but understanding what is the strategic intent. Are you coming out with this product to redefine the current standard of care? Are you looking to improve clinical and economic outcomes, and for who? Are you looking to increase ease of use in terms of the features and benefits? Are you developing the technology because of a competitive response? Maybe there's a competitor out there that developed a technology that you need to come out, with that might be better. Where does it fit in the care continuum? Understanding the disease or condition that you want to treat and what the patient journey is important to understand where your technology fits in the current care pathway. Who are the end users? Who is going to be using your product? And what behavior change will be necessary for your product to be adopted? This is something that I see innovators, I don't want to say disregard, but don't consider. Behavior change for any human is hard, especially for physicians who have been doing the same thing for many, many years, or their staff for many, many years, and there's no reason really to change. So are they going to want to change? Are they incentivized to change, or are they going to be disincentivized to change? The next one is really important. What is the unmet need? Is what's being done today sufficient, again, from the perspective of the stakeholder or end user? What they're doing now, again, is it sufficient? Is it broken? If it's not broken, don't fix it. That's often the mentality that we're dealing with. And is there really truly an unmet clinical need? So understanding that is critical. What is the business model? Next item. Is it a buy and bill business model whereby you are selling your device or technology to a provider or a hospital, and they're actually submitting that procedure or device on a claim to a third-party payer for reimbursement? Or is it a subscription type of service where you might have a digital health product and it's a subscription model where the provider is paying you a subscription fee or the patient is paying you a subscription fee? And again, what are the incentives and disincentives for market adoption in the various healthcare systems with the respective business models? And you might have two different business models for two different stakeholder types. What is the last but not least, what is the intended clinical and economic impact? And this is really, really important. We work with a lot of clients and prospective clients who very much focus on, with all due respect to the engineers, the features and benefits of the device. This device does this because of this great, engineering feature. Well, how does that feature translate to the clinical or economic outcomes for the intended patient population? So having that specific value framework and understanding and vernacular down is critical. So all of these things are so important. And I can tell you that, again, we work with a lot of clients who haven't necessarily thought this process out to the extent they need to. So really thinking about this early on is important. Next slide, please. So essentially, if we think about just from a pure reimbursement standpoint, there are essentially two pathways that you can go down. On the left is there are existing codes, there's existing coverage policies, and there's existing payment methodologies that I can, as a medtech innovator, piggyback off of for my technology. I'm just going to follow this path because I've validated that the codes that are available are appropriate for my technology. The payment is applicable, and there are coverage guidelines available, positive coverage guidelines, meaning that the payers, by and large, believe that the technology is medically necessary, and I can piggyback off of that. Or if we're going down to the right, there are no codes, there is no coverage, or there's no payment pathway that exists. These are two very, very different and bifurcated strategies. If we need to go down kind of the new reimbursement pathway route and develop specific coding and develop new payment models and develop the evidence to support coverage with the payers, that is a very, very lengthy process. It's about 5 to 7 years typically. I know investors don't want to typically hear that, but it's about a 5 to 7 year process and has been validated in publications versus that left side. Now, I want to say that each pathway requires evidence. Whether or not you have to develop your own codes or not, you still need to develop evidence, clinical and economic, to show the stakeholders at hand that your technology is valuable and, again, meets an unmet need. Okay, so just want to kind of show you those two different pathways. And going to the next slide, Ryan. One thing that's really important, and that is not necessarily the case within other countries, is regulatory and reimbursement processes in the US are not linear. It is not as if you go to FDA and get your clearance or approval and you go to CMS and automatically you have reimbursement and market access. There is not one entity here that centralizes reimbursement and market access decisions. Okay, next slide. The reality is really this, and it's kind of, a little bit of a funny, but here is, the FDA got my FDA clearance or approval, and then now you're really entering the maze of the crazy maze of reimbursement and market access. Next slide. And not all FDA pathways for medical devices are created equal. So just to kind of take the most commonly, it's, FDA 510(k) clearance with a predicate. So it's really not a 510(k) clearance is not approval. Technically, it is not an approval. It is a green light to market your device from FDA based on FDA's assessment that you are like something, a predicate that's already on the market. And essentially, there is no evidence that's required aside from bench testing, right? So there's no evidence. You're cleared, you're ready to market. Okay. We'll discuss later and throughout this presentation how that can be problematic for new and novel technologies in gaining market adoption and reimbursement. Okay. 510(k) clearance that's a de novo, a different type of clearance. There is nothing on the market that is comparable to your device, but it is not significantly, it doesn't propose a significant risk. So you can do the de novo as well. A little bit better, does require some evidence, but certainly, a little bit more than the clearance provides. But FDA approval or pre-market approval does require a significant amount of evidence and is specific for technologies that that could pose significant risk. But even with the FDA's requirement for a PMA approval and the evidence that's required for that, that's still not enough for market adoption and reimbursement. And again, we'll get into those details later. But it's important to understand that FDA indications are intended use statements for treatment or diagnosis of a disease or condition, but they don't confirm that a result or outcome is expected or will be expected if the product is used. Again, these are kind of two different mindsets, right? So if we go on to the next slide. Value lies in the eye of the stakeholder. I mentioned that before. Okay, so this is kind of a funny, you're developing a robot that screams. Well, maybe from a mother of 3, I might actually find that to be valuable for my kids, right? I want a screaming robot, but my kids, they might not actually think that's valuable, right? So understanding the value story and the value proof and the value proposition for your stakeholders is important. So the next slide, kind of get into this and understanding the different stakeholders that will be involved or could be involved for your product. Obviously, FDA from a regulatory standpoint, and they're looking at safety and efficacy, the payers, the providers, hospital systems are looking for the effectiveness from an economic and clinical standpoint, health outcomes, the clinical benefits. The coding authorities, there are multiple coding authorities here in the US. And again, Ryan will talk about this later in the deck. CMS, the American Medical Association, the World Health Organization, these are all entities that manage coding. Specialty societies, patient advocacy groups, these entities are relying on published data to make guidelines, coding recommendations, and for member education. So really understanding the full spectrum of the different stakeholders that are going to be relevant for your technology and what they're looking for and what's going to resonate with them is critical. Next slide. So kind of digging into 3 specific stakeholders here and kind of what their specific requirements are. If we look at FDA, they're again evaluating the device. And they're evaluating the safety and efficacy of the device specifically. Whereas United Healthcare, from a payer perspective, they're evaluating the impact that device has on the outcomes, health outcomes, and demonstrated effectiveness for a specific patient population. And this is really important based on the published evidence that's available. So payers typically want to see published peer-reviewed evidence in literature. Again, that's very specific to a finite patient population, okay? If we think about FDA, we always want our FDA clearance or approval to be broad, but the payers want to know the impact clinical and economically on a very specific patient population too. Again, 2 very different perspectives. The hospital systems or providers, they want to know, is there a clinical benefit for patients, obviously? They want to know, is there adequate reimbursement for the technology if they're buying it and bringing it into their facility? Is it going to increase the volume of procedures? Believe it or not, we are still based in we are a fee for service reimbursement, healthcare ecosystem. That is true. Value-based is here, but we still do drive mainly on a fee-for-service system. Is there cost avoidance of the technology? What is the budget impact of for the technology? Will it enhance the reputation of the hospital? Think about the Da Vinci robot. It enhanced the reputation for many of the hospital systems. And is there strong physician endorsement and demand? And it used to be for hospitals that's really all they needed was the physicians to really endorse or push the product. But now there are many other factors that are considered by the hospital systems. Next slide. I hear a little bit of background noise. So this is where the clinical trials and the data is so important. So in God we trust, all others bring data, and that can't be more truer than in reimbursement and market access and bringing that data to the relevant stakeholders. Next slide. So this is the value framework that we redacted from AdvaMed, and this is kind of something. This is a framework we actually use and work with our clients as they develop their evidence generation plans. And this is coming from, and this is actually, we suggest that it be implemented or incorporated into a target product profile, but understanding, again, kind of on the left side, who your primary stakeholder is. The patient, provider, hospital, the payers, private payers, commercial payers, and the Medicare and Medicaid population. Specifically for pediatric technologies, there's going to be a heavy Medicaid population in consideration. That's going to be a payer that you want to focus on. But what is the anticipated impact? And, from an example standpoint, looking at the clinical outcome improvement, risk improvement versus what's already available, reduced burden on caregivers, impact of out-of-pocket expenses. Maybe there's an impact on the economic, improved operational efficiency for the providers using the product. So really understanding that impact and those endpoints, and then developing the metrics that how we're going to measure that impact. Is it reduced mortality, lower length of stay, reducing the readmission rate, and then kind of last but not least, understanding and putting that into an evidence generation plan. And I want to kind of debunk the thought that every payer and every hospital wants to see, or hospital system buyer wants to see a randomized controlled trial, prospective randomized controlled trial. That's not necessarily the case. More and more payers will accept real world evidence, observational studies, information from registries, fit for purpose studies. So what are we really actually looking at and assessing and fitting that, kind of fit for purpose versus just doing an RCT because we think that everybody wants an RCT. So there are really many different ways of developing evidence to, again, demonstrate that value proof, not just value proposition. Next slide. And I think this is where I'm going to hand it to Ryan to go over the details and the U.S. reimbursement fundamentals. So we kind of, just to recap, you kind of notice in the first part of this presentation, again, I'm not really honing in on the reimbursement fundamentals, but I'm really giving considerations and planning recommendations for, again, that commercial strategy, right? That reimbursement is a very big component of. So this is where we get in kind of to the reimbursement details and fundamentals, and then you'll see it kind of all come together and tie in together as we go toward the end. So Ryan, take it over, please.
Thanks, Tanya. Okay, so based on this slide, there's a couple of key terms that you'll hear me talk to on subsequent slides, but just to make sure everybody's starting from the same operational foundation, the U.S. reimbursement system can be broken down into the following couple of key terms. Starting off on the left-hand side, benefit category. This is typically how Medicare perceives what type of health services they will establish policies for and coverage. And then, stratification of that against some of the other technologies or things that may be implemented into a hospital system that aren't paid for outside of, hospital acquisition of that technology, something along those lines. So not everything has a reimbursement path, but could have, to the points that Tanya has made prior, value to the hospital as a stakeholder. But taking it one step further, if there is an existing benefit category for the type of patient population, technology, et cetera, then we can dig a layer deeper into the coding, coverage, and payment. And so these three terms focus on a couple of key things. Coding, I think, is relatively self-explanatory in terms of this is on a transactional perspective, how different services are documented. The coverage is then a payer side of the equation, stating for specific procedures and their respective patient populations, what are they viewing as medically reasonable and necessary, and therefore, potentially willing to pay. And then on the payment side, again, relatively straightforward, but there are several payment methodologies that we'll get into, and some nuances that I think will be relevant to share. So we'll start off with coding. As Tanya had mentioned, there are several key stakeholders in charge of the four main coding systems. And you can see them based on their icons here. But as we go down this table, I'll kind of highlight a couple of key things. For the first row here with ICD-10 clinical modification codes, or CM. These are your diagnostic codes. So when a patient has a visit or procedure done, engages with our healthcare system, there is always one or more diagnostic codes that are applied to that patient's documentation. Moving one row down, the ICD-10 PCS, or procedural coding system. This is for tracking of services rendered in the inpatient setting. CPT, or current procedural terminology. This one is particularly owned and managed by the AMA. But this is probably the most commonly known type of medical coding system and characterizes the vast majority of procedures done by physicians. So it's helpful for management of physician procedure documentation, but it's also, when we get to the payment section, important for facility payment adjudication. And then lastly, on the HCPCS side, this is very similar to CPT in a lot of respects. And technically, CPT is a level 1 class subcategory of a HCPCS in general. But when people refer to HCPCS anecdotally, they're typically referring to the level 2 codes. These cover anything that CPT doesn't on a procedural side of the equation. And then in addition to that, covers things like durable medical equipment and other supplies, where you get very product-specific coding. So across these four types of codes on the left-hand side here, I'm a very visual person, so trying to lay this out in a clear manner as to how each of these four code sets are utilized with respect to the different billing methodologies. So in the first column here, the codes that are relevant for physician billing include that diagnostic code set, ICD-10-CM, across the top there. This is consistent across all three of these payment methodologies. But from a physician payment perspective, it's typically ICD-10-CM, a CPT code or multiple, and then potentially a HCPCS code or multiple. On the outpatient facility side, so this is hospital outpatient departments or the ambulatory surgery centers, or ASCs, they utilize, again, same three code sets. And then on the inpatient side, the main difference here is that instead of utilizing CPT, or sometimes there's HCPCS utilized, it's predominantly focused on the PCS codes and, again, the diagnostic codes at the top. So now that we've covered coding, which is really the mechanistic way of reporting what services are provided to a patient, and billing for those services to insurance, On the other side, when the insurer receives that bill, what they will look for is what do our coverage determinations, policies, et cetera, dictate in terms of what they will or will not be willing to pay for. So before we get into that, just a little bit of an overview in terms of what the US payer ecosystem looks like. So broadly speaking, it's broken down into one of three buckets. One, the largest of which is the commercial or private health plans. Secondarily to that is the public government health insurance programs. And then lastly, a little less than 10% of the US population is uninsured. And so based on the table here, I think it's self-evident to see that the largest payer of US health services is the commercial and private payers. And then secondarily to that is Medicare. And interestingly enough, if you split Medicare between Medicare and Medicare Advantage, which we'll get into in a slide in a second, Medicare Advantage is actually on the rise, which is technically Medicare that's administered by commercial payers. So this has been consistently the trend over the last couple of years, but commercial payers are the largest and they are growing in terms of share of the payer market. From a understanding perspective, I think it's important to start from Medicare and then work towards the private payer side of the equation. So Medicare has a very straightforward structure in terms of how it's set up between the four parts, part A, B, C, and D. And what you'll notice along the bottom here is that Medicare Part A and B are the parts that are administered by CMS. So Part A is for your hospital insurance, on the inpatient side or any place where a patient would be admitted, like a nursing facility, et cetera. Part B is probably the broadest of the buckets, and it covers doctor visits, durable medical equipment, laboratory testing, imaging, mental health, the list goes on and on. On the other side, Part C and D, these are extended Medicare parts where, like I mentioned earlier, private payer companies like United and others are contracted by CMS to help them administer Medicare. So Part C is basically the same as Parts A and B, but just run through those private payer systems, leveraging their infrastructure. And then Part D is for your prescription drug insurance. So we're going to talk about, on this slide, how does Medicare make determinations as to what they will cover and pay for versus not? And this is typically done through a process called a National Coverage Determination, or an NCD. Technically speaking, Medicare only has very few NCDs, whereas on the private payer side, they have far more extensive lists of policies. On the Medicare side, they only have in documentation, like through the NCDs or local coverage determinations, LCDs, they only have in writing documents for about 30% of all of the services they cover and pay for. The rest of it is largely silent, as we refer to it, coverage, meaning claims that get submitted to Medicare are covered and paid on a routine basis. And the rationale for why NCDs and LCDs are so infrequent is that these are not the same thing as coverage policies. One way to think about it instead, as I've talked with multiple Medicare directors, and the way they like to describe it is these are meant to be more of bumpers on a lane for directing for technologies that they feel are very highly costly or have a possibility of being very broadly used, very high claims volumes. And so it's more of a cost containment practice than anything else, or very specific bumpers to preserve, hey, here's the specific bounds in which the evidence that Tanya had mentioned in the earlier part is really proven out versus areas where it's not. So we're going to restrict coverage to this very narrow band until further clinical evidence is produced, and we may amend the NCDs or LCDs to kind of expand that. There are some other pathways that Medicare goes by which to update these. So your coverage with evidence development, this is meant for novel technologies like I'm sure those that everybody in the audience is developing and bringing to market. It's a pathway by which Medicare, if it's fairly complex, but if you can basically convince CMS that your technology is one in which this is an unmet need for the Medicare patient population, and that during evidence development it would be beneficial to have coverage. This is a pathway. There's also a new pathway called TSET for those who are familiar, and relatively new, with very few companies having gone through it just yet. So there's a lot of evidence still developing out of that program. Administration of Medicare coverage is broken down into a couple different geographies. So while I mentioned the national coverage determinations and that Medicare establishes this for all states, there are local administrative contractors that actually execute the administration and payment of those claims. And so those are broken down based on 12 different geographies and 7 different entities that cover those 12 geographies. And they have the ability, if there's not a national coverage determination, to write a local version of that to help with administering what they will or won't pay for and streamlining that process for themselves. And then in addition to that, I had mentioned Medicare Advantage growing. So here on the left-hand side is a projected Medicare Advantage enrollment through 2030. And with the recent changes within the staffing of CMS, this projection, if anything, might increase. Medicare Advantage represents the majority of the Medicare patient population, so patients that are older than 65, plus anybody on disability insurance or would otherwise qualify for Medicare. The majority of that now is Medicare Advantage. On the other side of the government payer equation, to talk briefly on Medicaid, health insurance for children is mostly broken down into commercial and Medicaid. As you can see on the graph on the left-hand side here, that the blue represents commercial insurance and that the remaining sections in gray would be Medicaid. And then in addition to that, Medicaid is more than just children. Just in case anybody wasn't aware, there are millions of individuals enrolled on Medicaid as well as enrolled in CHIP. And if we take a closer look across total children enrolled in Medicaid and CHIP, the largest enrollments by state are the following 6 states. So California, Texas, Illinois, New York, North Carolina, and Florida. And if you break down that enrollment, it's still several million enrollees. But these 6 states represent about 44% of all Medicaid enrollment for children. The other thing to note is that in these 6 states, and I think it's true across all states in general, but just representative in these 6 states, that the majority of that Medicaid is managed Medicaid. So again, commercial companies that are administering Medicaid benefits. So another example of how commercial companies are a predominant force in the U.S. reimbursement system. And so based off of all of this, I think the question that a lot of us ask in the entrepreneurship environment is, what do payers want to see? And it really comes down to your evidence generation planning. What they want to see is a very clear and concise picture of what is the standard of care right now for a patient that comes in. How many times are they engaging with the healthcare system? What does that look like over the period of a year to 2 more years? And what are the costs associated with those interactions with the healthcare system over time? And then what your job is as a innovator in the space is to very clearly lay out a story of a future of care, juxtapose that with the standard of care, and show them where you are introducing efficiencies, shall we say. Are you reducing the number of hospitalizations, for example? Are there fewer necessary office visits? Things of this nature, where you can lay out the two stories very clearly and then back up your future of care with clinical data. So as Tanya had clarified, FDA evaluates the device. The payers are evaluating the outcomes, and they specifically are looking at that future of care story. How much of that have you proven? And across all your publications, how much overlap do you have? Is it, the full story is told, but it's really only 2 publications, or do you have more than that? Are there segments of that story that you have not proven in a clinical trial yet, or multiple? That becomes very important. In addition to that, have you looked not just at the clinical outcomes, but also the health economic outcomes to monetize the clinical value? These are very important elements. In addition to what they're looking for, there's one point that we want to emphasize here, is that payers can have a medical policy stating that a new service is not covered. So basically, they find that there's not enough clinical evidence for them to make an assertion that they have confidence in this type of technology. But at the same time, payers can decide to pay individual claims for a service based on medical necessity. So they're interrelated, but not necessarily interdependent. And the vice versa is also true. So just because there is a coverage policy that says, hey, we think your technology is medically necessary or backed up by your clinical evidence, payers can still deny on a claim-by-claim basis, because really claims are determined on a claim-by-claim basis for that specific patient population, or, for that specific patient against the broader population. So with the next couple of slides, we're going to emphasize this key point, but we brought it to the forefront in that achieving consistent, reliable reimbursement and broad market adoption for new tech is an iterative process. As Tanya mentioned, it is not a linear process. And so to emphasize that, Stanford Biodesign back in 2021 did a study looking at new innovations on the market and how long it took to get widespread coverage. And so the national average here is actually close to 5 years. If it's a truly innovative type of technology where there's not an existing coverage policy, or on the Medicare side, coverage determination or LCD, it takes a long time. And a lot of that comes down to the payers catching up in reviewing of all of your clinical evidence, and also that a lot of technologies come to market thinking that the FDA is that hurdle. We talked about some of these fallacies early on, but the clinical evidence sometimes isn't really well flushed out and published before coming onto the market. So there's a natural lag there in terms of accomplishing the additional clinical trials necessary to get coverage. So the sooner you can think about that in your FDA strategy timeline, the better. All right, and then so to close for today, we're going to talk through a couple of common mistakes and how to avoid them. So mistake number 1, full focus on regulatory and R&D plan with no attention to reimbursement and market access plan. I hope that what we've emphasized in our talk today, the need for thinking about the bigger picture and all of the stakeholders involved in terms of really getting market adoption of your technology and success there. Mistake number 2, not understanding your patient journey, current workflows, and technology value. This is where it's really important to go through an exercise of mapping out the standard of care. What is that patient's journey? What are the workflows for the users of your technology? If it's a clinician that's using it or implanting it, is it the patient that's using it, et cetera? And who is the person that's paying for the technology? What are their pain points, right? What's the value in the eye of the stakeholder, as Tanya mentioned? Mistake number 3, not knowing your stakeholders and their perspective on value and applying a one-size-fits-all value proposition. You could have many value propositions across the various stakeholders. Don't assume that any one covers more than one stakeholder. It's very important to go through that value analysis exercise and that framework that Tanya had shown, because that's a good way of kind of going through it and thinking through things. But then your value proposition is only as good as your value proof in your clinical trials. So backing up that value proposition needs to be done. Mistake number 4, not having an end-to-end evidence generation plan beyond what's required for FDA clearance or approval. So I think we beat this one pretty well across all of the different slides, but it's very important to think about that future of care timeline I talked about, and are you covering that in its entirety? If you're an imaging technology, for example, that helps physicians with diagnosing, you can't just think about, oh, I just need to do clinical trials to show the sensitivity specificity. You got to show the proof that if you put this into the hands of a physician, is it going to actually result in a behavior change? And what is the impact of that behavior change? So don't think myopically. Mistake number 5, conducting early market access with only friends and family for VOC feedback. So what I would recommend here is, before you conduct some of the bigger interventional clinical trials, vet and validate your protocols with a lot of the key stakeholders. Go to the clinical societies. They have industry representative boards where they can talk with you about your clinical trial designs. Get their feedback as a society. One of the services PRIA offers is opportunities for engagement with payer medical directors, getting their input on, does this trial actually address endpoints you would want to see? Nobody wants to have to get on the market and then go back and redo a clinical trial because you missed a crucial endpoint. And then lastly, mistake number 6, developing your reimbursement and market access plan based on coding only. We have a lot of clients come to us saying, hey, we really just want to understand, can we use these codes? Don't go code shopping. There is a very complex, bigger picture that we hope we conveyed in our slides today that needs to be taken into account, because coding is just one element in the bigger picture. And with that, we'll pause for some questions and discussion. Thank you, everyone, for your attention.